Uveitis. Uveitis classification. Anterior uveitis, mostly sterile inflammatory reactions. Iritis, iridocyclitis, keratouveitis. Anterior uveitis, inflammation of iris and or ciliary body, whether acute or chronic. Etiology. Acute anterior uveitis. Human leukocytic antigen B27 related diseases as ankylosing spondylitis, Reiter syndrome, reactive arthritis, inflammatory bowel disease, psoriatic arthritis, and post-infectious reactive arthritis. Acute anterior uveitis may also be caused by F.R.S. syndrome, glaucoma. Anterior uveitis, inflammation of iris and or ciliary body, whether acute or chronic. Etiology. Acute anterior uveitis. Human leukocytic antigen B27 related diseases as ankylosing spondylitis, Reiter syndrome, reactive arthritis, inflammatory bowel disease, psoriatic arthritis, and post-infectious reactive arthritis. Acute anterior uveitis may also be caused by F.R.S. syndrome, glaucomatocyclitic crisis, lens-associated uveitis, phacolytic glaucoma, intraocular lens-associated postoperative inflammation, viral iridocyclitis caused by herpes simplex, herpes zoster, adenovirus, or infectious mononucleosis. Drug-induced uveitis can also be met. Chronic anterior uveitis is met when inflammation lasts for more than 3 months, as in juvenile idiopathic arthritis, Fuchs heterochromic iridocyclitis or Fuchs uveitis syndrome, and idiopathic iridocyclitis. In anterior uveitis, the acute phase is related to chemical mediators released from mast cells. Histamine is released early in acute inflammation. Kinins are released in subacute and intermediate response. Complement and clotting system, prostaglandins and leukotrienes are released in chronic and prolonged response. Or out of the vascular channels. Serous exudates with predominant protein component as aqueous flare in iridocyclitis and subretinal fluid in rhegmatogenous detachment. Sanguinous exudates with predominant erythrocytes component, hyphema. Purulent exudates, predominantly composed of polymorph nuclear leukocytes and necrotic products, as in hypopion. Fibrinous exudates with predominant fibrin component, as fibrinous iridocyclitis. Cellular changes include polymorph nuclear leukocytes margination and active emigration to extracellular space, followed by mononuclear macrophages and passively by red blood cells, diaperesis. Acute phase is transient and lasts for 3 to 5 hours in absence of a continuous stimulus. Juvenile idiopathic arthritis. Chronic inflammatory arthritis present for more than 6 weeks in children less than 16 years of age. It is seronegative arthropathy. Polyarticular form, less than 4 joints affection. It's associated with uveitis in 20% of cases. Positive antinuclear antibody titr. Human leukocytic antigen DR5 positive. Juvenile rheumatoid arthritis is responsible for 75% of anterior uveitis in pediatric age. In juvenile idiopathic arthritis, there is a chronic non-granulomatous uveitis that is bilateral in 70% of cases. 50% of cases develop moderate to severe uveitis. 25% of cases develop mild uveitis lasting less than 4 months of age. 25% have severe form and ocular complications as band keratopathy, cataract, and secondary glaucoma. Behçet's disease. This is a generalized chronic non-granulomatous occlusive vasculitis that is common in Eastern Mediterranean population and Japan. It affects young adults 20 to 30 years of age and is bilateral with various risk factors such as HLA, B5, and B51 positivity, factor V Leiden mutations. There is small or moderate-sized blood vessels vasculitis. The following may occur as ocular features of Behçet's disease in 75% of cases. Acute and chronic non-granulomatous uveitis with transient hypopion, occlusive arthritis and periphlebitis leading to hemorrhagic retinal infarction and retinal detachment. Also, ischemic optic neuropathy. Systemic features of Behçet's disease: oral aphthous ulcers, genital ulcers, skin lesions including erythema nodosum, superficial thrombophlebitis, and subungual infarctions, non-destructive recurrent arthritis affecting the wrists and ankles, central nervous system affection, encephalopathy, strokes, or peripheral neuropathy, nerve pulses. Phacoanaphylactic endophthalmitis or phacoantigenic uveitis. This is a rare autoimmune inflammatory response to lens proteins. It is an immune complex disease that develops when normal tolerance to lens protein is lost. It necessitates previous exposure to lens proteins, following trauma, surgery, leaking lens proteins in hypermature cataract. In 20% of cases, no history of trauma or penetrating wound is found. Pathology. There is zonal chronic granulomatous inflammation. Polymorph nuclear leukocytes infiltrate central lens material, then epithelioid cells and non-specific mononuclear cell infiltrate follows. Zonal pattern caused by antibody-antigen ratio in immune complexes. Concurrence with sympathetic ophthalmia in 3 to 7% of cases despite being unrelated immunologically. Intermediate uveitis or pars planitis. This is ocular chronic non-granulomatous inflammation of ciliary body, peripheral retina, and pars plana, with spillover of inflammatory cells in vitreous, snowballs, or inferior pars plana, snow banking. The affected age is the third decade of life. It is bilateral in 80% of cases and constitutes 10% of all uveitis cases and 25% of pediatric uveitis cases. Intermediate uveitis is idiopathic in 90% of cases. Intermediate uveitis may also occur secondary to specific entities, as multiple sclerosis, where intermediate uveitis may develop in up to 15% of cases, sarcoidosis, syphilis, tuberculosis, Lyme disease, peripheral toxocariasis, primary Sjogren disease, and human large T-cell lymphoma. There is dense opacification of the vitreous base, pars plana, and plicata. Microscopically, there is condensed vitreous, snowball infiltrates, vitreous infiltration with loose fibrovascular tissue formed of blood vessels, lymphocytes, fibrous astrocytes, and non-pigmented epithelium, peripheral focal choroiditis, and peripheral periphlebitis and retinal neovascularization. The disease carry a good prognosis on vision with mild to moderate exacerbations and remissions. In children, rapid progression occurs in 15% of cases with poor prognosis. However, visual loss may occur as a result of cataract, cystoid macular edema, retinal detachment, retinal neovascularization, vitreous hemorrhage, epiretinal membrane, and macular ectopia. Intermediate uveitis is self-limited in 10% of cases. However, it runs a chronic course in 90% of cases with remissions and exacerbation in 30% of cases. Visual prognosis depends on cystoid macular edema, anterior segment complications like complicated cataract and secondary glaucoma, cyclitic membrane, and tractional retinal detachment. Posterior uveitis. This is ocular inflammation primarily involving the retina, choroid, or both. It could be infectious or non-infectious. Infectious posterior uveitis could be caused by viruses like herpes simplex, herpes zoster, varicella zoster, cytomegalovirus, Epstein-Barr virus, rubella, measles, or subacute sclerosing panencephalitis. It could also be caused by bacterial agents. Fungal agents include ocular histoplasmosis syndrome, candidiasis, coccidioidomycosis, and cryptococcosis. Protozoal infection may also cause infectious posterior uveitis, as in toxoplasmosis, and helminthic agents include toxocariasis, cysticercosis, and diffuse unilateral subacute neuroretinitis. Non-infectious posterior uveitis, autoimmune disorders, collagen vascular diseases, systemic lupus erythematosus, polyarthritis nodosa, and Wegener's granulomatosis, pigment epitheliopathies, idiopathic, and masquerade syndrome. Pathology of posterior uveitis, retinitis, inflammatory cellular infiltration presenting as diffuse retinal whitening, vasculitis, periarteritis and periphlebitis, cellular infiltration around veins, patchy and irregular, candle wax dripping, severe inflammation around veins. Vitritis, inflammatory cells, flare, and posterior vitreous detachment. Choroiditis, inflammatory cellular infiltrates presenting as discrete, deep yellow lesions, associated retinal pigment epithelium hyperplasia or atrophy. Tuberculous chorioretinitis. This is affection of the choroid by Mycobacterium tuberculosis, due to hematogenous spread from a distant focus or upsurge of tuberculosis in recent years with AIDS infection. Pathology: vitritis, choroidal granuloma, and papillitis. Choroidal granuloma could be single or multiple, yellowish with indistinct borders, flat, one or more disc diameters in size, becomes elevated with overlying serous retinal detachment. There is chronic specific granulomatous inflammation. Toxoplasmic chorioretinitis. This is posterior segment infection by Toxoplasma gondii, which is an obligate intracellular protozoon. It is the commonest cause of posterior segment infection worldwide. It could be congenital with reactivation of a dormant focus or acquired. In toxoplasmic chorioretinitis, there is old chorioretinal scar in the posterior pole. Adjacent unifocal area of acute onset inflammation is seen as pale yellow elevated lesion with fluffy borders and overlying vitritis and inflammatory cells. Perivasculitis and arteriolar narrowing are also met. Ocular histoplasmosis syndrome. There is a tetrad formed of choroidal neovascular membrane, juxtapapillary atrophic pigmentary changes, peripheral punched out chorioretinal lesions, histospots, and absent vitritis. Ocular histoplasmosis syndrome occurs in healthy young adults in areas endemic with systemic histoplasmosis, yeast infection, fungus histoplasma capsulatum. There is positive reaction to histoplasmine skin test in more than 90% of cases. Fungus has been recovered from choroid of cases affected with histoplasmosis. In ocular histoplasmosis syndrome, there is peripheral choroidal granulomatous or non-granulomatous infiltration. The macula shows choroidal infiltration, subretinal neovascular membrane, fibrovascular proliferation with collagen and cells, retinal pigment epithelium, lymphocytes, plasma cells, macrophages, vascular endothelium, photoreceptors, myofibroblasts, RBCs. There is also serous or hemorrhagic retinal pigment epithelium detachment. Infectious posterior uveitis, viral posterior uveitis, acute retinal necrosis syndrome. This is fulminant necrotizing viral retinitis in healthy individuals, caused by herpes viruses like herpes simplex type 2 and varicella zoster, or by cytomegalovirus. It is bilateral in 33% of cases. Acute retinal necrosis syndrome, or ARN. There is anterior segment inflammation with a triad of occlusive retinal arteriolitis, heavy vitreous cellular exudation, multifocal yellowish-white peripheral retinitis. ARN runs a progressive course and coalesces forming a circumferential confluent creamy retinitis. The posterior pole is paired. There is slow resolution and poor visual prognosis. Viral posterior uveitis, herpes zoster. This is neurotropic virus inducing chronic unilateral iridocyclitis, perineuritis, and perivasculitis affecting posterior ciliary arteries and nerves. Pathology: cutaneous vesicles, patchy necrosis and postnecrotic atrophy of iris, anterior segment ischemia, retinal perivasculitis, nonspecific choroiditis, retinal artery occlusion, scleritis, and keratitis. Orbital vasculitis results in cranial nerve pulses. Viral posterior uveitis, cytomegalovirus retinitis. This is necrotizing retinitis with hemorrhage in immunocompetent patients, caused by double-stranded DNA virus as herpes virus family. Neonatal cytomegalovirus retinitis, or as frequent ocular manifestation of immunocompromised individuals. HIV positive 28 to 45% of patients, leukemia or lymphoma. Viral posterior uveitis, cytomegalovirus retinitis. There is focal retinitis, primary coagulative necrotizing retinitis with secondary choroiditis, yellow-white areas of retinal necrosis, hemorrhage, vascular sheathing, and attenuation, mustard and ketchup fundus, microaneurysms, and capillary non-perfusion are also seen. In large cells with Ohl's eye, Cowdrey type A is eosinophilic intranuclear and small basophilic intracytoplasmic inclusions. Non-infectious posterior uveitis, pigment epitheliopathies. It is a retinal pigment epithelium choriocapillaris disease with inflammatory swelling of retinal pigment epithelium. It heals with scarring. Pigment epitheliopathies could be caused by vascular or ischemic insult to choriocapillaries resulting in retinal pigment epithelium infarctions, or as autoimmune response directed against retinal pigment epithelium. There is overlap between clinical entities. Acute multifocal placoid pigment epitheliopathy, AMPPE. It is a bilateral condition affecting young middle-aged females. Preceding flu-like or upper respiratory tract infection is present. There is rapid onset of diminution of vision. Acute anterior uveitis, vitritis. It appears as deep focal pale swollen lesion, 1 mm with fluffy borders. The lesions evolve in phases and resolves with subretinal pigment epithelium scarring in 2 to 3 weeks. Multiple evanescent white dot syndrome. This is a unilateral condition affecting young adult women and is common in myopes. In multiple evanescent white dot syndrome, there is acute transient decrease in vision and paracentral scotoma, vitritis, multiple small pre-equatorial white dots at the level of the retinal pigment epithelium, foveal granularity as thin yellow-orange dots at level of retinal pigment epithelium, optic disc swelling, and subretinal neovascular membrane. Panuveitis. This is an inflammation affecting iris, ciliary body, and choroid. In panuveitis, there may be associated systemic disease. It is bilateral. Causes include infections as tuberculosis, spirochetal infections as Lyme disease, syphilis, leptospirosis, helminthic infections as onchocerciasis, river blindness. Immunologic and granulomatous diseases like sarcoidosis, sympathetic ophthalmia, Vogt-Koyanagi-Harada disease, endophthalmitis, and panophthalmitis. Vogt-Koyanagi-Harada syndrome. This is bilateral panuveitis associated with exudative retinal detachment. The affected age is 20 to 40 years. Oriental, dark pigmented skin individuals are affected. Hemoleucocytic antigen HLA-DR4, HLA-DRW53, and HLA-DQW3 positive. Heredity may play a role. Pathology. Types: anterior type, Vogt-Koyanagi type, granulomatous or non-granulomatous uveitis. Posterior type, Harada type, granulomatous or non-granulomatous. There is T-cell mediated reaction against melanin-containing cells in uveal melanocytes, central nervous system, and skin. Diffuse non-granulomatous choroidal infiltrates with T cells and B cells, macrophages, and multinucleated giant cells. Late loss of choroidal melanocytes with retinal pigment epithelial atrophy and thinning of outer retina. Choroidal neovascular membrane is present. Systemic features of Vogt-Koyanagi-Harada syndrome. Neurologic manifestations: inflammatory meningitis with fever, malaise, nausea, and vomiting. Auditory manifestations: inflammatory otitis with tinnitus, sensory neural hearing loss. Cutaneous manifestations: poliosis, madarosis, vitiligo, and alopecia. Ocular manifestations: anterior segment manifestations include iridocyclitis with cells and flare, iris nodules, saguaro sign, paralimbal vitiligo, cataract, and secondary glaucoma. Posterior segment early manifestations: vitritis, exudative retinal detachment which is bilateral, early involves posterior pole, becomes extensive with shifting subretinal fluid, and choroidal thickening. Early manifestations also include focal white lesions at retinal pigment epithelial level and optic nerve hyperemia. Late manifestations: irregular areas of retinal pigment epithelial hyperpigmentation and atrophy. Multifocal atrophic chorioretinal scars. Endophthalmitis. This is an inflammation affecting one or more coats of the globe and adjacent cavities, with non-involvement of the sclera. Clinically, it usually means vitreous involvement. Panophthalmitis. A suppurative endophthalmitis that spreads to involve the sclera and orbital tissues, as extraocular muscles and orbital fat. Etiology of endophthalmitis. Exogenous, due to entrance of organisms from external environment. Bacteria introduced through perforating corneal wound via foreign bodies is an example. Common organisms include streptococci, gram-negative bacilli, and fungi. Endogenous. Organisms gain entrance into vascular channels as metastatic septic emboli or through perineural spread. Common organisms include bacteria, meningococci and nocardia, fungi, candida, and aspergillus, protozoa, toxoplasmosis, viruses, cytomegalovirus, herpes simplex virus, and varicella zoster virus. Bacteria cells produce their cytopathogenic effects through direct tissue invasion or lipopolysaccharides, endotoxin production with gram-negative bacterial cell walls.